just typically the deposition would be at a law firm in a conference room, so this is why we're sitting at a table right now.
And usually I'd be across from her, so she'd be questioning me right across. So it's not usually where we're sitting next to each other. Just in case I wanted to punch her, you want to make sure that there's a distance between the attorney. Yes.
So in this case, you're an attorney for the plaintiff?
I'm an attorney for the plaintiff, and he's the doctor, who would typically have an attorney with him.
I mean, I'll sit next to him, but I'm not going to object. I'm going to let him answer every single question. But yes, so these are the only people who would be present during a deposition, in addition to the court reporter. Although I had a case recently that the plaintiff showed up. And in doing this over 30 years, there are only two cases in which the plaintiff actually showed up to the doctor's deposition. This one and the other lady was crazy. This lady is a normal, nice lady.
So first the doctor would be sworn in by the stenographer, so we can assume that has happened. Doctor, are you licensed to practice medicine in the state of New York?
Yes, I am.
And when did you become licensed?
About 2006.
Has your license ever been suspended or revoked?
No.
And have your privileges to hospitals ever been suspended or denied?
Nope. I don't know.
Have you ever been placed on probation for any reason?
What do you mean by probation?
Has your license been placed on probation?
No.
And doctor, I see here that you graduated medical school in 2010. Can you tell me, where did you do your training?
I did my training at the University of Cincinnati School of Medicine, Department of Emergency Medicine. And I was wrong about my license. I was licensed in 2010, not 2006.
Okay. Now, and where did you do your residency?
At the University of Cincinnati also.
Okay. Since you completed your residency, have you worked as an attending physician in emergency medicine?
Yes, I have.
Okay. And can you tell me what you did as where you have worked as an attending physician?
I'm here at KCH in the emergency department.
And you've worked here ever since?
Yes,
Ever since you've become an attending physician?
Yes, that's right.
Okay. Now, doctor, have you reviewed anything in preparation for this deposition?
Yeah.
And can you tell me what you reviewed?
I reviewed the patient's chart.
Okay. And did you meet with your attorney in preparation for this deposition?
Yes, I did.
How many times?
Too many. It was a lot, yeah.
Doctor, have you done any research in preparation for this deposition?
What does that mean? Research, what do you mean?
The issues that are relevant in this case, have you researched them to be more prepared to testify today?
It's funny, my attorney told me not to, but, I figured it'd be a good idea to do some stuff of my own. So, yeah, I looked some things up on the computer just to make sure I was ready for this.
So if I were representing him, I would have, said something to him about saying anything that we had discussed or any advice that I had given him.
Usually not a good idea to say my attorney told me X, Y, Z.
And I'd also take him out of the room and probably yell at him.
Now, doctor, you said you did research in preparation for this deposition, and do you also do research before you treat patients in the emergency room?
Well, if things come up, if I'm not really familiar with something, or if I want to make sure that I'm giving good care to a patient, we'll look something up. We have literature in the ED. We have computer terminals that I can look something up really quickly if I need to.
And so you, despite your busy schedule and the high volume of patients in the emergency room, you stop and do some research?
Not all the time. If I think I need to, then I will.
And did you do research here when you treated this patient?
I don't remember this case. I don't know.
So, doctor, and that was my next question, you don't remember treating this patient?
No.
So is it fair to say that everything I will be asking you and your questions your answers with regard to this patient would be based on the documentation in your chart?
Yeah, I mean, I don't remember her at all, so it would be based on the chart.
Okay. Now, doctor, as an attending physician, what are your responsibilities?
Well, in an emergency room, you're saying?
Yes.
Have you ever been to an emergency room? I mean, it's pretty crazy, especially here in Brooklyn. You know, people are coming in at all hours of the day and night. So as an attending, I'd be responsible for meeting with the patients after their triage, after they meet with the nurse. I would, if the patient's able to speak, I'd speak to the patient, try to assess what he or she is feeling, where the pain is, if there's pain. If they can't speak, I'd speak to a family member if someone's there. But it basically, as an attending in an ED, it's very busy, so you have to figure out who you're admitting, who you're going to let go. And you got to make sure that you do that as efficiently as you can.
Okay. And doctor, you supervise residents as well, is that correct?
Yes.
Okay. And doctor, you are responsible for ordering the necessary labs, blood work to diagnose a particular condition.
If it's indicated, sure.
Okay, as well as radiology studies if necessary.
Whatever's necessary indicated, yeah.
Okay, and doctor, would you say that if you did not order the necessary labs to diagnose a particular condition, that would be a deviation from the standard of care?
And what do you mean by deviation?
Well, that would be a departure from the standard of care.
If I didn't order something?
Correct.
Oh, yeah, absolutely, yeah.
Okay. Now, doctor, in determining the risks, in determining whether to order a particular study, you would weigh the risks and benefits of that study. Is that correct?
Well, I mean, you look at risks and benefits, but more importantly, you have to see whether or not a patient needs that type of test. If she doesn't or he doesn't need the test, I'm not really concerned about what the risks are. I wouldn't be ordering the test.
Okay, but assuming the patient needs that test, you would still weigh the risks and the benefits.
Whatever's best for the patient, yeah, we consider that.
So if the risks outweigh the benefits, you may consider not ordering the test.
Yeah, that's a possibility, sure.
And if the benefits in leading to the diagnosis outweigh the risks, you would order the test. Is that correct?
Again, it's very patient specific, so typically, yeah, if the benefits outweigh the risks, then I would order a test or have someone take some blood on the patient if it was warranted, yes.
Okay. Now, doctor, what is the significance of a patient who presents with flank pain?
What do you mean significance? I mean, everything's significant. You know, whatever my patient says is significant to me.
Okay, well, what is flank pain a sign and symptom of?
Well, I mean, it could be a sign of getting punched. It could be a sign of pulling a muscle. It could be a sign of falling down. It could be a sign of getting shot. It could be a sign of straining something in that region. There's a lot. I would need more information. You know,
Okay.
flank pain by itself could mean a lot of different things.
Okay, so could flank pain be a sign of a urinary tract infection?
Under certain circumstances, yeah, I guess.
Okay, and can it be a sign of cystitis?
I mean, things aren't that easy in the emergency room. So, I mean, I'm not sitting there saying, you know, could this be a sign of this? I have to figure out what's best, what's most reasonable. But I mean, yeah, anything's possible. Sure, it could be cystitis.
So you would agree that it could be a sign of cystitis?
Yeah, why not? Sure.
Okay.
Sure.
Now, doctor, what is the significance of the symptom of burning on urination?
In any situation, you're saying? With this area, I mean, it could be urinary tract infection. It could be, there might be some microscopic tears in the lining from the uterus down to the vagina. It could be, it could be nothing. It could just be that the person's not well lubricated in that area. It could mean a bunch of different things.
Okay, would you agree that if a patient comes in with a complaint of burning on urination, it's hard to distinguish whether that complaint is burning or pain or both or one or the other?
Well, I'm not in that person's head, so whatever she says or he says, I can only take at face value.
But you would have to take the necessary history to derive at, as best as you can, what the source of that complaint is.
That's my job. You know, I'm there to take a history. Assuming, again, the patient is able to speak and is not, there's nothing going on with their mind where they have some difficulty in speaking, yeah, I would try to assess that as best I can.
Okay. Now, doctor, would you agree that if left untreated, a UTI would get worse?
I feel like I'm back in medical school. I mean, yeah, sure. If it's left untreated, it could get worse, yeah.
In fact, doctor, would you agree that that's the case with really any infection? If left untreated, it progresses?
Not in every situation.
But certainly in some situations.
Yeah, sure. Some situations things get worse, yeah.
And certainly, would you agree more often than not, if you don't treat an infection, it becomes worse?
I mean, I can't give you percentages. I mean, if you're asking me if it's 52%.
No, I'm not asking you percentages, just more often than not. Would you agree with
Yeah,
that?
why not? That sounds about right.
Now, doctor, would you agree that tachycardia is a sign and symptom of an infection?
Would I agree with that solely? No.
I mean, but can it be a sign and symptom of an infection?
I mean, it could be a sign and symptom of an infection. It could be a sign that someone's very nervous. It could be a sign that someone has some blockage. It could be a sign of many different things. Tachycardia in and of itself. I can't sit there and say, my patient's got a heart rate of in excess of 100 beats per minute. She or he must have an infection. It's not that easy.
I understand, doctor, but it can be a sign of an infection.
Yeah,
Is that correct?
it can be,
Okay.
yeah.
Okay, doctor, now, would you agree that some urinary tract infections present without a fever?
Yeah.
Okay. Now, doctor, what are the risks of not treating a urinary tract infection in a timely manner?
Timely means what?
Well, just when, as soon as can be possible.
Well, nothing can happen. It can resolve. It can get worse. It can develop into sepsis. And that's pretty much, nothing can happen or really bad things can happen.
And you had just indicated, doctor, that more often than not, if you don't treat an infection, it progresses.
Those are your words, not mine.
But you had said that earlier.
I don't remember saying that.
But do you have a reason to disagree with that statement?
Do I have to answer this? I mean, what's
So in this case, I would have the court reporter read back his answer a few questions earlier, and that would be the end of that. Now, doctor, are women who are recently postpartum at a greater risk of infection?
I don't know. Maybe, maybe not. Depends.
Okay, so you don't know, as a physician who's been practicing medicine for many years, that women who are postpartum are at risk of an infection?
Is she allowed to do this? I mean, I'm a busy guy here.
Doctor, are you?
Yeah, of course I know.
Do you not know?
No,
Is
of
that
course I
your
know.
answer?
Every patient's different. That's what I'm trying to tell you.
Okay, but as a whole, did you learn in medical school that women who are postpartum are at risk of an infection?
You know, you didn't go to medical school, right?
Doctor, that's not my question.
I mean, you're attacking my ability to practice medicine now.
I'm just asking a simple question.
What's your question?
So did you learn in medical school and in your training that women who are postpartum are at a greater risk of an infection?
They're at a risk. I don't know if I'd say greater. They're at a risk of infection.
But they are more of a risk of getting an infection than somebody who has not been hospitalized and possibly have undergone surgery or a vaginal delivery a few days earlier. Would you agree with that, doctor?
Yeah, a woman that gave birth is more at risk than I would be. Let's put it
Okay,
that way.
okay, fair enough, fair enough. Now, doctor, so if you see a woman in your emergency room who is a week postpartum, would it be important to you to ask that woman whether she had a vaginal delivery or a C-section?
Absolutely.
Okay, and why is that?
Well, C-section is a major surgery. You're susceptible to different types of risks at C-section versus normal spontaneous vaginal delivery. But again, if you deliver naturally, you're at risk for other infections as well. But I would want to know because it's important.
Okay, and then what are the risks of a vaginal delivery when it comes to an infection?
Well, again, there could be damage to the birth canal. There could be issues of whether or not the mom was group B strep, positive or negative. There would be issues about whether or not she received what she received in terms of tocolytic agents, if any, if she had an epidural or not, if she was on antibiotics for any reason during the labor and delivery. So those are things I would want to know.
Okay, and so you would certainly ask those questions if a woman presents to you to the emergency room with having a history of having a delivery.
That's my usual practice,
Okay.
yes.
And to not do so would be a departure from the standard of care, is that correct, doctor?
Yep, absolutely.
Oh, okay. Now, doctor, are women who are recently postpartum, are they at risk of mastitis?
I don't know if I'd say at risk. I mean, it happens quite often. The breast tissue becomes infected or enlarged. It can become painful. So that would be a situation where typically the moms would say to me, you know, I'm trying to breastfeed my child and it's very, very sore, very tender. So that's not necessarily on
Okay.
in my
So,
practice.
but that it would be important to, as a physician who is evaluating a woman recently postpartum, it would be important to consider mastitis if a woman presents postpartum with symptoms of infection.
No, I wouldn't say I'd consider it. It would have to be something where the mom would tell me something about either pain or discomfort, or well, women typically will come in very engorged because they're producing milk for their babies. So that would be something you would expect. So that's not mastitis, that's just the nature. So again, it really does depend on what the mom is telling me. If she just says, you know, my breasts are very sore or tender to the touch, that's one thing. I would need more information in order to really start to consider mastitis and differential.
Doctors, are you saying that a woman cannot have mastitis if she does not have tenderness of the breast?
What I'm saying is if a woman makes no complaints about pain to her breasts, I'm not considering mastitis.
Okay, now, doctor, so you would not order labs to see whether there's an elevated white blood cell count, whether the urine studies are normal. You would not do that?
You know, I have patients coming in complaining of, you know, massive head pain. You know how hard it is to get a CT scan for them? You think I'm going to get a test for a woman that doesn't complain of chest pain or pain to her breast? No, it doesn't work that way.
And you would not examine that patient's breast?
If she made no complaints, I would not examine her breast. No.
And that is your testimony?
That's what I just said.
Okay. Now, doctor, let's turn to your note in this case. And let's take a look as well at the triage note. Now, we see here that Ms. Smith presented to the emergency room on February 16th, 2017 at 3:42 a.m. with a history of being 1 week, or more specifically 8 days postpartum, and she has a generalized body ache, pain level 10, flank pain, and a pulse rate of 113. Okay, so that's the background. Now, doctor, on presentation, did you form a differential diagnosis?
I don't remember. I have to look at the chart.
Okay, doctor, now can you read your short note into the record, please?
Sure. Just grab that picture. Okay, this is February 16th, 2017, 4:50 in the morning. The patient is a well-developed, well-nourished, in no apparent distress. Vital signs: temperature 98.9, pulse 113, respirations 20, blood pressure 113/64, O2 sats 99% on room air, HENT, the head was normal cephalic, adramatic, extraocular muscles are intact, pupils equal, round, and reactive to light and accommodation, nares appear normal, mouth is well hydrated without lesions, mucous membranes are moist, posterior pharynx clear of any exudate or lesions. You want me to go on?
Okay, you can stop there, doctor. Now, doctor, what was the significance to you of the fact that this woman had a pulse of 113?
Well, it's slightly high. It would be considered tachycardia. The significance would be, again, she is 1 week postpartum. She's in an emergency room at 3:40 in the morning here in KCH. People get nervous. That can increase the heart rate. It wasn't to a level where I'd be considering something more serious than that. It could just be a benign finding, but it would require more workup, and that's what I was doing.
Okay, but it's very possible that it would not be a benign finding as well.
Very possible. I mean, it's possible.
Okay, so you just said that it would require more of a workup. And what workup did you do in this situation?
Well, perform the physical exam, ask questions, try to elicit some type of information from the patient to figure out what was causing her complaints of pain.
Okay, now doctor, your note indicates that this patient also complained of flank pain. that correct?
Let me look again. Yeah, I see another note where I wrote that, yes.
Okay. And based on the complaint of flank pain, what differential diagnosis did you form?
Well, again, I don't remember the specifics. I'm just looking at the note. I see here that my differential essentially was complications post-delivery. So my thought process most likely was the fact that she'd come in with this history. As I'm looking at my note, she delivered 8 days earlier. Baby was full term, no complications. She had 4 days of back pain, left-sided flank pain without trauma. Again, she denied fevers and chills, which is important because that would go against considering an infectious process. She denied abdominal pain, so again, that worked towards what I was thinking here. It was most likely based on the presentation, based on her symptoms, based on her complaints, based on my own judgment, these were complications from post-delivery. And I believe we would have discharged her with instructions to come back if the pain continued, if it got worse, or if it spread to other parts of her body.
Okay, now, doctor, you had indicated here that she has burning with urination, but more likely irritation of mucosa status post-delivery rather than dysuria. Is that correct?
Yes.
Okay. And how did you form that assessment?
Well, again, I've seen many women that come in after giving birth. This complaint is fairly common. So in my judgment, based on what she had said, and in the absence of any other factors such as fever or chills, it was my conclusion that this was most likely the result of just that type of irritation to the mucosa that is the result of giving birth.
Doctor, did you examine the pelvic area in this patient?
You mean internally or externally?
Either way.
No, there was no reason to.
Okay. So you had indicated earlier that a woman who was withdrawn. Now, so you had just said that you formed a conclusion that this was an irritation of the mucosa, so that was just kind of your hunch?
You didn't go to medical school, right?
I mean, that's not my
I mean,
question,
a
Doctor.
hunch? No, it's clinical judgment. It's not a hunch.
Okay, doctor, you had indicated earlier that a woman who is postpartum is at a greater risk of an infection.
No, I didn't say she was at greater risk. You said that. I said she could be at risk. Yeah, I agreed with that.
Okay, and you had agreed that she was at greater risk of an infection than a person who did not have that history.
No, I said she was at greater risk than me because I didn't give birth to anybody.
Okay, then somebody who did not just give birth. Doctor, is there any evidence in this record that you asked the patient whether she delivered vaginally or by C-section?
Yeah, there's evidence.
Can you show me, doctor?
I mean, it's written right there. Did I write down whether it was vaginal? No, but what I do is I ask my patient. And if she tells me something, for instance, if she said it was a C-section, I would write down, I examined the scar to determine whether or not the staples were still present. I was looking for erythema. There were things that I would write down that would cue me to remember that I would have asked that question. But I always ask that question.
But there's, based on your note, which records your assessment and treatment and physical exam of the patient, there's no evidence that you asked the patient that history.
Well, the evidence is what I wrote. So looking at this, I mean, again, I don't remember if she gave birth vaginally or if it was a C-section, but based on what I wrote, that
Doctor, you
would
had
mean to
indicated
me.
earlier, since you don't remember, your testimony is based on the record here.
Right.
Because you don't have a memory of this patient.
Yeah, that's what I said.
Okay, so again, based on your note, you did not ask the patient whether she delivered vaginally or by C-section.
What do you mean based on my notes? Based on what is written there, I didn't write it down. That's what you're asking me. No, I didn't write it down.
Okay.
But I know from what I do in the ED that I asked her those questions.
Okay, doctor, did you ask the patient whether she delivered vaginally?
I don't remember specifically, but I must have.
But, you must have.
Yeah.
Doctor, did you examine the pelvic area?
I don't remember.
Okay, so doctor, even though this patient was at an added risk of an infection because she just delivered, you did not examine the pelvic area.
Again, these are your words. I mean, I guess you have your theory you got to try to prove here, but I never said she was at an added risk. I said that based on my assessment of the patient, there was no indication for me that there was an infectious process because there was no fever, no chills. So, I understand what you're trying to do here, but that's not what I was thinking back in February of this year.
So you agree with me that based on this record here, you did not examine the pelvic area of this patient?
I don't know.
Okay. And according to your note, you did not, is that correct?
According to my note, there was no indication to do a thorough examination of the pelvic region based on her complaints and presenting symptoms.
Okay. And doctor, in fact, based on your note, if this woman did have a C-section, you did not examine her incisions, whether there was any drainage?
No, that's what I said earlier. If she told me there was a C-section, I would have written down examined scar for erythema, for dehiscence. I would write certain things that would mean to me that I examined it. I mean, if I sat there, again, you're not an ED doctor. When you're an ED doctor, it's like that, okay? You've got one patient, you've got two patients, you've got 20 patients, you got so many beds in there. So if I sit down and I take my time and I write down every single thing I do, either handwritten or on the computer, people would drop dead because I don't have, there's just not enough time in the day to do all that, okay?
But yet
So
that-
I write, one second, I write stuff down that'll help me understand what I did, so that if I have to go back, I read something, I say, all right, I may not remember the patient, but I know based on what I wrote, this is what I did. I can't write everything down. You wouldn't understand that because you're suing me. But if you understood what it's like to be in an ED, you would see that you're running from one patient to another, and you've got family members screaming and yelling. There's a lot going on. People are dropping dead. That's what I do. Okay, so no, I didn't write it down. I didn't write everything down.
Okay, doctor, were you taught in medical school that you should document significant findings?
Ma'am, when you're in medical school, you're sitting in a room, okay, you're 300 other people, you're either hungry, thirsty, tired, bored, and you got someone that hasn't practiced in 100 years telling you what to do. Yeah. Do they say, you gotta document everything? Sure. Okay? And then you go into the ED and your head's spinning around, and you realize there's no way in hell you can document
Doctor,
everything.
I move to strike the unresponsive portion.
Why are you
Doctor,
striking? What's a strike?
Okay, doctor, would you agree that negative findings, so meaning if a patient did not have a certain complaint, can be also significant findings?
I don't know what that means.
Well, if a patient does not have a certain complaint, that is also an important finding. Would you agree with that, doctor?
You mean like a pertinent negative if they deny X, Y, Z? And yeah,
Yes.
it helps lead me to other differentials, sure.
In fact, doctor, would you agree that the purpose of medical records are not just for you? You keep talking about yourself. But if this patient were to present to the emergency room, say in a few hours, as she did, and somebody else, another attending, was evaluating her or resident, they would want to know what the patient's baseline was a few hours earlier. And the only way, and the medical record would be for that very purpose.
They could also call me if they had any questions.
Okay, but is it fair to say, doctor, you could be on vacation, you could be busy with another patient?
I guess that's fair, yeah.
Okay, and what they have to go by is the medical record, doctor, is that correct?
Well, the medical record and what the patient's telling them at that time.
In fact, doctor, I would like to show you that based on the note of the physician who evaluated the patient just a few hours after you did, when she represented with the
When did she
worsening
come
of
back?
symptoms. Just a few hours later, and I'll be happy to show you the note. It says, rule out significant for gross hematuria that began at unknown point over the same time course, at unknown point. Had you taken a thorough history, it would have been useful for that physician because that point would have been known. Do you have any reason to disagree with that, doctor?
What are you attacking me for? What are you saying?
It's a yes or no question.
I don't even understand the question. She didn't complain of hematuria when I saw it. So if she did, I would have written it down.
Well, but doesn't this doctor says that it's unknown when that complaint started? Had you
Sure.
written it down,
Well, I
you would
can't
have
write
known
something
that
down
that
if she didn't
complaint
tell
did
me.
not exist.
But if she doesn't tell me, am I going to read her mind? She didn't tell me she had that history.
But it's not important to ask that history?
If she told me that, I would have written it down.
But doctor, would you have any reason to disagree that had you written that she does not have that complaint, that the physician who evaluated her the next day would have known when that complaint started?
Well, she must have told him it was unknown. So if she doesn't know, how am I going to know?
Now, doctor, did you ask the patient whether she has pain on urination?
If I wrote it down, I must have asked her.
And if you didn't write it down, you didn't ask her?
No, if I didn't write it down, it means that she denied it. Because I don't write down pertinent negatives. I just write down pertinent positives.
Okay, and the fact that the next day when she represented to the emergency room, it said, the note of the physician who evaluated her said that she had pain on urination that began during her earlier presentation. Do you have any reason to disagree with that, doctor?
Again, I would never disagree with a colleague. That's what the patient told him at a given time, or her at a given time. It is what it is.
So based on the fact that she gave a history of having pain on urination at the time of your presentation, and the fact that you did not write it down, you did not ask her that question, did you, doctor?
No, I wrote in my note here, let's see, that it was more likely irritation of mucosa than dysuria. So I definitely spoke to her about it. It was just, again, my assessment. I looked at everything, I listened to what she said, I reviewed the constellation of symptoms that were there before me, and that was the judgment I rendered. I said it was more likely this than that. But we also told her, look, if it continues, come back. And obviously it continued, she came back, and they worked her out.
Doctor, but you agree that earlier you diagnosed an infection, the better the outcome?
You're saying if I diagnose or just generally?
In general.
Yeah, sure. You know, the earlier you get anything, the better, right?
Doctor, is there any indication in your record? Now, doctor, we withdraw. Doctor, you had indicated earlier, and as we see in the chart, this patient had flank pain. Is that correct?
Yep.
When somebody has somebody presents with flank pain, isn't it important to assess the patient's costovertebral angular tenderness?
For flank pain? Without anything else? No.
Okay. Now, doctor, what are the signs and symptoms of polynephritis?
Well, you can have pain in the lower back. You can have bilaterally, like across your lower back. It can be flank pain. Generally, you have fever, you have body aches, chills, almost like a flu type of presentation. But the pain would be mostly in the back, obviously where the kidneys are. So that's where you would feel the pain. It can sometimes it goes down your legs, you know. So if that's all you're complaining about is lower back pain, you might be thinking sciatica. So you need more information. You know, just flank pain or just lower back pain is not going to make me think right away, like, this guy's got polynephritis. I might think, you know, well, did you lift something? Were you working out? Did you do something else? You know, in this case, did you go down to lift your baby? Did you aggravate anything in your back? So that's where I would be thinking more. I need more information to start thinking that this is an infectious process of the kidneys.
Doctor, is suprapubic tenderness a symptom of a urinary tract infection?
Is it a symptom of it? I mean, it could be, sure.
Okay, doctor, is there any evidence in your record that you asked the patient whether she had suprapubic tenderness?
I don't know. Let's see. Let me just look. I don't remember, and I don't see anything in the chart.
Doctor, would you agree? Doctor, are there any risks of ordering labs in a patient to reach a diagnosis?
You mean like blood labs?
Or urine?
I mean, urine, you're just peeing into a cup, so I can't think of any risk. Blood, you know, some people are scared of needles. Some people might have small veins. You know, you could cause sometimes you can cause perforation. It can develop into a compartment syndrome, I guess. So there's a lot of bad things that can happen by drawing blood.
And would you agree that blood and urine studies help diagnose an infection?
Yeah.
Okay. And doctor, do you have any reason to disagree with the fact that had you performed labs on this patient on the day that she presented, and were those studies positive of an infection, you would have started treatment?
I mean, you're asking if I took blood and it showed a certain finding? Yeah, I would treat it, sure.
I have no further questions. You guys get the idea, hopefully.
All right. So now we're actually going to discuss the case and also do sort of a Q&A about Mr. Ross' presentation.
Let me just flip to the other side. So what were your general impressions of the witness? Anybody could volunteer?
Absolutely terrifying.
there-
seems like you'll be led into saying so much stuff that you don't want to say, that you know is going to sound terrible.
Yeah, that often happens during a deposition. Any other comments? Yes?
It seems that he may not have prepped enough with his attorney because his answers were very long-winded and he was offering much more information than was being asked. So it kind of does his whole
Very good. So that just leads into, so basically these are just some hints, basics at a deposition. So preparation is the key, and you have to know what's in the chart. And it might sound very simple, but in representing doctors for years, you're in practice, you're very busy, and obviously you're bright, you learn things very quickly, and you tend to be able to look at something in a very short period of time and understand it. So it's perhaps counterintuitive for you to really study the chart, but you have to study the chart and know it completely. Doctors often, no matter how many times you tell them, they don't master the chart, and they think because the chart is available during the deposition that they could just read the chart then and get by on it. But that's more or less kind of a recipe for disaster, because what happens at a deposition, and we didn't really have time for it today, is that deposition nowadays begins after background information, is they ask you general medical questions. And so the witness, when asked general medical questions, they answer the questions freely, which is the purpose in answering them, and they often answer them without realizing the nuances of their particular care. And so they'll agree that in a certain set of circumstances, in a particular condition, they'll order certain tests, not realizing that in this chart for this particular patient, they never bothered to order that test. And so that creates problems for them. So it's really important. In law school, they have open book examinations once in a while. I don't know whether they ever do that in medical school, I doubt it. But some law students, make the mistake that they figure you don't have to study for the exam because you're going to have the book in front of you and you just open the book to the answer. And they realize right after the exam that that didn't work out so well. Because of the time constraints, you're nervous, you're anxious, and the pressure, it just doesn't work. And also for you, you have to look on the chart. So unlike Ralph, you should never admit that anything you did or didn't do is a departure from good and accepted practice. If you do that, you're admitting to medical malpractice, okay? And we don't want to make any case a simple fact question. So sometimes they tricked you and they ask you, assume that you didn't do this, would you agree that that was a departure from good and accepted practice? And you think to yourself, well, I know I did that, so I'll answer that question, yes, that's a mistake. So you should try to answer that question, Don't be absolute and answer those questions, not necessarily. And as someone pointed out, don't volunteer any information, okay? Obviously, his answers were much too long-winded. You just want to answer the question as succinctly as you possibly can. And also, we didn't get a chance, but you're going to be asked whether you accept something as authoritative. So do you guys use Rosen's on emergency medicine? Do you ever use the text, refer to the text?
Yes, Rosen's.
Rosen's, right, I think it's 3 volumes. And the last one, you probably never look at, it's dermatological. But anyway, if you accept the text as authoritative, the problem is that at trial, you could be read the text, and juries are very impressed by medical text or books or magazines or journals. And so you could be read from it whether you agree or disagree what's in a text. And so if what you treated is in contrary to what's said in the textbook, you're going to be in trouble at trial. And moreover, once you accept something as authoritative in a case today, like 5 years from now, you're still going to have to accept it as authoritative. You're going to be stuck. So even though the text might support your care in this instance, maybe 3 years from now. In another case, it may not, and it's likely that the other side will know about it, and so you're going to be forced to admit that it's authoritative again. So it's not a good idea. Don't say anything critical of colleagues, and that seems fairly obvious. But sometimes depositions, the questioning can get rather intense, and you feel, under pressure, and we've had situations where they will get somebody to admit something's critical of somebody else, and it's bad for both parties. I had a case in one hospital, a neurosurgeon and a critical care attending, and the neurosurgeon testified first, and then the critical care attending was about a head injury, basically a traumatic brain injury, and the claim was that the patient developed vasospasm afterwards. And in any event, so they did the neurosurgeon. When they got to the critical care attending doctor, they started to ask him about neurosurgery and whether or not he wanted neurosurgery to see the patient every single day, and he sort of resisted. And then they read selected excerpts from the neurosurgeon's testimony, which in his state, he assumed that the neurosurgeon was being critical of him, and so he went against the neurosurgeon. And he said he would have liked to have her see the patient every single day, and the neurosurgeon, had given testimony that could be criticized him in some respects too, so it winds up making a real mess for the trial. And basically, so one of the other things is that you're not testifying about care based upon your recollection only, okay, which Ralph said it's based upon the records only, but he should have answered the question, the records and general customs and practices, okay? Because we don't write everything, none of you do. We all do things ordinarily, and even though it's not written, we don't remember the specific patient, we do it. One of the other things, I don't know where it develops in medical school, but there are residents who I work with who are in their final year and witnesses, and they seem to come when you speak to them about a case, and they seem to think you're never supposed to say you remember the patient. So when you ask them to remember, no, I have no recollection. They seem to think they have to go by the chart, and that it doesn't help them if they say they remember the case. And the reality is that's not true, okay? Because, it may be an easier time to get through the deposition, but you have to think about the trial. And the trial is really what's most important, obviously. And if the jury, lay people, would expect you to remember the case for a particular reason, you're going to come across as cold or uncaring if you don't remember a horrific disaster that befell. And we all know you remember, your worst cases, you remember, you live with them, and you're not likely to forget. So that's a mistake you should not make. And also, don't answer any questions about your care before looking at the chart, okay? Even though you've studied the chart and the chart's in front of you, they're in the EBT, always look at it before answering the question. Ralph and I were assistant DAs for a while, both in the same office, and I was in homicide for a long time, tried a lot of murder cases, and we had assistant DAs would write homicide cases when the defendant, the suspect, I should say, was going to make a confession, and it would be videotaped. And so the assistant DA goes to speak to the person, and of course first gives them his rights. And so I had a homicide case, and the assistant DAs who do that are, practicing 4 years, and how long, and you don't have to really go to law school to know what the rights are. From watching TV, you probably all do. Anyway, he didn't bother to read, and he gave the suspect his rights, he confessed, and then I had the trial in a murder case, and there's always a hearing before the trial to test the admissibility of the confession. And in my office, I watched the videotape, and he missed a right. He forgot one. And that's fatal to the confession. And it should be So you always have to look at it, and they're trained to read it from a card, never to do it from memory. Similarly, testifying, you always have to do it. In my case, there was the hearing, amazingly enough, the defense attorney who's really experienced and the judge who's supposed to pay attention. Because everybody knows the rights, they didn't even pick up the fact that a right was missed. So the testimony, the confession was admissible, the guy got convicted, and it was sustained on appeal. And basically also resist the natural impulse to convince the other side that you're blameless. So basically going into the deposition, the doctor always wants to convince the other side, it's just natural, that they didn't do anything wrong and lay out all the defenses and to tell them why everything they did was appropriately. That's a mistake, okay? That's not going to dissuade them from continuing the case. And basically the less information you give, the better about the defense, because that means we're in a better position at trial with respect to the defense. Sort of like at a war, the less information your enemy knows, the better. And it's the same thing with respect to a trial. So we have some time left. Do you guys have some questions? Yeah.
So thank you very much. That was very interesting. It brought back terrifying memories. I've been in positions. So a couple of very important points that I want to just emphasize, and they just made a lot of really good points. No matter how sweet and lovely and nice the opposing attorney may seem, they are there to make you look as bad as possible, right? They really are. You're not going to become friends with that person. You're not going to convince them that you're a good person and you're a great doc and you had a bad day. So just look at that person like they are, at that point, your enemy. Right? And that's really what you have to do. The second thing is get out of the emergency medicine mode where you have to answer so quickly. Really think about what you're going to say before you say it, and again, say as little as you need to say. Imperative that you meet with your attorney. Imperative beforehand, because what another good thing to do is to look at your attorney when you're asked a question, and you could read that person's face, and they could, they would be, and at any time you could just ask to speak with your attorney in private. So really take your time. Get out of the emergency medicine mode where you're pop, 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 pop. You're going as fast as you can. It's okay to take a break. It's okay to really just think about your answer before you say something. It's not going to make you look any worse.
Those are all excellent points. I mean, the transcript's going to look the same whether you answered the question immediately or you paused and waited 15, 20, or 30 seconds to answer the question. And I know you want to get out of our offices as quickly as possible because it's distasteful, but you should really take your time answering the questions. Go ahead. Yes, sir?
I actually work for a lot of review cases, and I can't stress enough what Dr. Lakeith said, don't offer more information than you're asked. If you're asked the yes or no question, just answer yes or no. I can't tell you how many times I've read stuff where the doctor thinks they're being helpful and trying to explain things, and it ends up making such problems. So give as little information as you possibly can while you answer their questions. Don't give them anything extra. It's really, really just not going to help you.
Go ahead.
I want to come back to discovery. You mentioned about emails and preserving evidence. So when they're asking for evidence, how do emails that you have between colleagues, like you were saying, if you email, like sometimes after a shift, we'll email a resident to give them an update that happened with the patient. Let's say that case ends up before the trial. How would that email become discoverable, or how would they even know the existence of that email?
They'd only know through the existence by asking you.
Okay. And so the general question is, did you email about this case
So,
to anyone?
I'll tell you honestly that so sometimes doctors text with patients or they have electronic communications with patients, so those things that other side will know about and they may ask about it. They usually do not ask about whether you have any email communications with any colleagues concerning the patients, but they do ask about communications with other patients. Now technically, communications may include emails, back and forth. If you do say yes, they're going to ask you whether you have them, and they are discoverable, and we'd have to turn them over. So it's a different world with respect to that. Sure.
And just like thinking about how I would prepare, like just myself, like I would read every possible thing about this case, like outside of it, all the data, all that kind of stuff. Or are you just like kind of damning yourself if you give that information? If you're like, you know, I know you can find out exactly the percentage of cystitis that moves on untreated to become pyelonephritis. You can give that percentage in this deposition as an example.
Okay.
Like, is that a fact that you should just don't give, or what do you do with information that you know?
Okay, so you shouldn't volunteer information. So I mean, there was a show on HBO, I think it was, about Mormons. Did you see it? Everybody saw the show. So basically, one of his wives is married. She's underage when she's married. She goes to the deposition prep, and they tell her, the lawyer, only answer the question. There are only 3 answers you can give to each question. Yes, no, I don't remember. Okay? It's an exaggeration, but it's not that far from the truth. Okay? You have to restrict your answers. As far as doing research, honestly, so when I meet the doctors, we meet the doctors early on in the case, okay? So we'll meet them, we'll discuss the case way before their deposition. And we'll talk about it, and honestly, we give them an idea that they will be asked questions about medical practices and about standards and about the particular condition at their deposition. And the reality is that at that point in time in assisting us, you could do research and everything else, okay? That's fine. And so when it comes close to the deposition, it's subtleties, but you tell them, don't do any research to prepare yourself for the deposition. So in other words, when they ask you the question, did you do any research to prepare for it, the answer is no. But you could have done research to, you know, when we met, to assist us in understanding the case. Obviously, it's your case, even though we're the attorneys representing you, you have a particular interest in, so you could impart that information to us. But don't give that information to the plaintiff's attorney. The reality, I mean, just like he said, you know, some attorneys are obnoxious, and they put you in very uncomfortable positions right from the get-go. They will ask, you know, about board certification. And if you're board certified, they're going to ask how many times you sat for the exam. Some of them are, you know, more definitely like you failed it the first time, you failed it the second. I mean, they'll try to get under your skin. They will ask questions, you know, if you didn't attend a medical school in the United States, they'll ask you, did you apply to any medical schools in the United States? Did any accept? I mean, they do a lot of obnoxious things, some of them. On the other hand, others are just really nice, so they develop a rapport with you. But the reality is they're not your friends, they want your money. Despite whatever they say, they want to show you were a bad doctor and you committed malpractice here. That's their aim, okay? And that's what they're trying to do.
If I can just add one point, I think what doctors, we're lawyers, and as doctors, you're completely removed from the process. What's important to keep in mind is that a deposition is not a trial. So at the end of the deposition, and it is sometimes videotaped, but more often than not, it's not videotaped. So at the end of the day, all you have is a transcript. You're not trying to convince a jury the way you see on television, where they're making judgments about you as a doctor, what kind of people you are, credibility judgments that we do every day. At a deposition, all that comes out of it is a transcript with questions, answers, question, answer, question, answer. And those, so it's a different mentality for that reason, different strategy. And that's the reason that you want to say less than more. You want to convince the other side less than you would ordinarily think. You're not there defending yourself. It's just a transcript that the other side uses to prepare for trial or to pin you at trial if you say something damning. So,
if I can add to that, and then we'll get to your question. The one thing I was trying to do was answer very impulsively, to answer without thinking. And typically, if you give a response without thinking, what happens? You have verbal diarrhea, so you say a lot more than what you want to say. What I always tell my clients in depositions is, as you see, the enemy is the one asking all the questions. My attorney was just sitting there not saying anything. That's typically what happens, and doctors will say, well, wait a minute. If my attorney is not asking me any questions, the enemy's asking me all the questions, they're controlling everything. I'm not controlling anything. So what I tell my clients is, this is how you can control a deposition while your attorney's silent. Every time a question comes in, listen to the whole question, even if you think you know where they're going. Remember one thing, you're the expert in the room, okay? Whether you're an emergency medicine doctor, a neurologist, an internist, you're the expert. We work like hell to learn this stuff. You guys live and breathe this. So don't forget that. When you come into the deposition, you might be nervous, you might be angry, like I was trying to be angry. You might be all these things, but the one thing you are above all that is the expert. You guys know this stuff cold, you really do. Bring that into the deposition. Don't check your experience at the door, but listen to the question, make sure that you understand the question. A lot of times doctors will say, you know what, this attorney doesn't know what the hell he or she is talking about. I'm just gonna throw some stuff out there because I want to get out of here. That's the worst thing you can do. If the question doesn't make sense to you, all you say to the attorney is, I don't understand your question, please rephrase it. The one thing you don't want to do is say, I don't know what you're saying. If you're trying to ask me ba-ba-ba, if you try to rephrase the question, well, now you're the expert on this side of the table and the expert on that side of the table, and you'll be cross-examining yourself. Never rephrase the question. They're getting paid to ask you a question. If you don't understand it, let them rephrase it. The next thing you do before you answer it, you never want to be impulsive, as was said a few times. If you answer impulsively, if you answer without thinking, you will more likely than not completely hang yourself. Think before you speak. I tell that to my doctors all the time. Make sure you understand the question. Once you understand the question, ask yourself before you open your mouth, what is the issue, medically speaking? What is the attorney getting at? What is the medical issue? Understand that first. And then, again, before you open your mouth, the next thing you're going to do internally is, all right, here's the medical issue. How can I answer this, as we've all been saying, as concisely as I can? So you're not trying to sort of mislead someone. You're not trying to obfuscate. You're not trying to hide stuff. But what you are trying to do, to get to your point, is if I understand what he or she is asking me, I'm only going to answer that issue. So I'm not going to volunteer all this information that I have, because like Wayne said, we can use that at trial. And your transcript is going to be given to an expert. She is going to take my testimony, and she's going to pay someone 10 grand, literally $10,000, not to agree with what I said, but to shred everything I said. Even if what I said was medically sound, their expert's getting paid a lot of money to make you look like a total buffoon, okay? It's just the way it is. So if you have good information that isn't necessarily responsive to the question, and we hold that in abeyance, well, now their expert's not going to be given the heads up, all right? So they're not going to know that you have all that good information that will totally refute what they're trying to say. So while your inclination is to try to, I'm going to show this person why they should let me out of the case, why I should be discontinued, that doesn't happen. So again, the best way to control a deposition is to think, remember you're the expert in the room, and to make sure that before you open your mouth, whatever comes out of your mouth is well thought out, is reasoned, and concise. Because if you start BSing, like I was, I gave her information and I'm going to get crucified at trial. So that's the best thing to remember. Even if you're nervous as hell, I tell my doctors after we prep for hours, if you forget everything that I've told you, the one thing I want you to remember, think before you speak, because that is absolutely critical.
So basically, you're just providing evidence against yourself. That's what a deposition is.
The other side's learning about your case, about the case.
Worst case scenario.
Worst case scenario.
Potentially hanging yourself.
That's what you do.
You can be.
You're never providing defense for yourself in a
No,
deposition.
no, no, I would disagree with that, because if you're putting forth your clinical judgment, okay, like in this case, I was looking at the constellation of symptoms, and based on everything that was at my disposal, be it her own complaints, my own observations, I exercised my judgment to go this way. So you're establishing what your defense is. She's going to disagree, obviously, but if I establish my defense, then our expert will come in and say, you know what, that doctor exercised reasonable clinical judgment. You're not going to be perfect. But the judge, like Wayne was talking about, when she gives instructions to the jury, one thing she's going to say is you're not held to a perfect standard. You're held to a standard about what other doctors would do reasonably within the community. So I understand your point. You feel like everything I say they're going to use against me. Yes and no. If you're establishing your defense that you've discussed with your attorney beforehand, if you put that forward in evidence, that she's going to disagree, but we will now have a chance to go forward with it.
Sure.
So I think I've learned a lot about like what happens when you get sleep. Like in my experience, I've probably seen 100 of these back pains like this year. These have all come back with like a slight fever and then septic from pyelonephritis. Hours later. We try to document, to communicate with each other, but also to